So I'm going to give you a little exposure to um, an area of ENT surgery which is drifting towards us more and more. 12 years ago in this hospital, parathyroid surgery was done by endocrine surgeons, as it was in many, many hospitals in this country. Now, the head and neck lot in a lot of DGHs and many teaching hospitals are getting less work for two reasons. One is the number of patients with types of head and neck cancer which we used to operate on are getting less. And a lot of patients, especially oral cavity, oropharynx, oropharynx and hypopharynx, who in the past used to have massive radical surgery, are getting better results with chemoradiation. So I used to do laryngectomies a lot. Now I do a lot of parathyroids. And from the patient point of view, it is a condition which has an extremely high cost to quality of life. The vast majority of patients, hyperparathyroidism, which manifests with hypercalcemia, has very subtle effects. Now we all feel that at a certain age people slow down, they get tired more quickly, they get aches and pains. But it doesn't help that in addition to that, you have a raised calcium level which has not been diagnosed, and most patients who haven't had a blood test, they would just blame forgetfulness, tiredness, fatigue. Oh, I'm just getting old, till the calcium is done. Now, in the past, most of these patients would wait, and those of you who were here on Friday, yesterday, may have heard Mr. Saba's talk, in which he talked about stones, moans, and groans. Now, 20, 30 years ago, patients with hypercalcemia would wait till they had these things and they would come, or they had a fracture. Today, a lot of patients, they come with these sort of subtle symptoms, and because of the availability of the various blood tests, a lot of GPs just do these tests, simple calcium, and then the penny drops. So that is that, but then the patient arrives in our clinic, and not very long ago, even I would say 10 years ago, and even now, many of these patients would undergo very big operations, because as you know, there are 4 parathyroid glands, and they would undergo 4 glands exploration. My predecessor here, very experienced surgeon, but then we have to move on, and I'm sure the guy who will replace me will say the same thing about my practice. So the guy before me would do a 4-gland exposure, would do 1 patient in 1 list. Patient would stay 2 days in the hospital. I do 4 parathyroids in 1 list. All of them go home within 4 to 5 hours of the surgery. The incision is 1 inch. Now the credit goes, in my opinion, for focused parathyroid surgery, the credit goes to the radiologist. And this is just one of the areas where we work together for the benefit of the patient. So you see here, I've put asymptomatic within apostrophes, because this is what happens. The patients feel that the symptoms they're relating to are not really because of some problem. It's just, oh, I'm getting old. But I mean, in my practice, the most thank you cards I get from my patients are patients from parathyroid, because once the surgery is done, their whole life changes. And the best bit which I like is, it's not only their life changes, the people around them also appreciate it, because their children, their partners, and their friends say, oh, he or she is a different person now. She's more cheerful, doesn't forget things, and more active, etc. So we need to know where it is. I'm not going to go into the detailed anatomy of the parathyroid gland, but the parathyroid gland normally is stuck behind the thyroids. That's the easy bit. A good number, especially the inferior parathyroid glands, could be anywhere. Like this one. This is in the superior mediastinum. Now, if you're a decent head and neck guy, you can spend all day in the neck, but you're not going to find this. So if you've got a very good radiologist, as we are very fortunate to have here in Doncaster, he'll forewarn you that you've got a problem, your gland is not in the neck. Now, this patient of mine was referred to Sheffield, and there was a surgeon there at the time who's since retired, Mr. Harrison, and the thoracic team took it out without any major issues. So the role of the imaging is to detect the lesion, and then this is just a diagram showing you of the ranges of the calcium, but this is the important one. The vast majority of patients with hyperparathyroidism have calcium levels that bounce around in the range, intermittent normals. Now this is happening because the parathyroid hormone secretions can also variate, but essentially it's this is the hyperparathyroid patient that you're going to see in your clinic. Once they cross 3, they're very symptomatic. And I mean, we don't have any GPs in the audience, but if you're a general practitioner, you better listen to them. And if you're in a endocrine clinic or a parathyroid clinic and somebody is referred to you for hyperparathyroidism and they do not have an up-to-date calcium and they say that their symptoms are like that, do repeat calcium, and you would be surprised, or I think you shouldn't be surprised that if the calcium is above 3. Age group, the vast majority are in the 50s and the 60s. For some reason, these glands show up in older patients than younger. As a matter of fact, if they're in the 20s or earlier, you would be advised to seek help from your endocrine team for a MEN screen, because sometimes it's associated with the multiple endocrine neoplasia. I mean, I had one guy who was 17, and that's his adenoma on an ultrasound. He did not have an MEN, but that's the youngest single gland adenoma that I've taken out. So what does preoperative localization allow you? Now, this is the bit I was just saying to you compared to my predecessors. So it allows reduction in operating time by up to 50%. I think it's even more than that now. My average theater time, including intraoperative PTH, frozen sections, the whole lot, is between 60 and 70 minutes. There's an extremely high cost savings. For those of you who may remember, the winter pressures every hospital has, there are no beds. I actually keep most of my parathyroid patients, if they can wait, to be done between October and April, when the hospital is struggling for beds, because they just come in, stay a few hours, and they go home. Unilateral neck exploration essentially means that you can make the incision where the radiologist tells you the gland is. Obviously, it's a small scar. I am not in the business of endoscopic parathyroid removal, and I'll be upfront. It is a good skill. Some people do it. But from my practical point of view, the incision that I use is 2 centimeters. The average time is 60 minutes. The complication rate is less than 1%. The endoscopic incision, the time and the complications cannot match that. So I don't see the benefit, but yes, some people do it. Patients are extremely happy. I mean, those patients who have the procedure done like this, they are really, really happy. And like I said, the complication rate, we've audited our results and we've published it as well. And we've shown that our pickup rate is, pickup means successful biochemical outcome in over 350 patients has been 95, 96%. So how do we do it? The key, and I repeat again, is your radiologist. So you can find a surgeon, but in bigger print, find a good radiologist. A variety of nuclear medicine techniques is also used, but high resolution ultrasound and sesame scan is what you're going to watch. Now again, yesterday Mr. Saba mentioned some techniques which like 4D and fluorescence and things like that, and gamma probe, etc., for the difficult ones. But if 95% of your patients are going to be cured by simple investigations, it's these two. So in our trust, we have a protocol. No parathyroid patient is referred to an ENT surgeon or a parathyroid surgeon till they have both the scans. I keep all the other scans in reserve if the first two scans are not indicative of where the gland is. So how does the sesame B scan work? Now you need to understand this because there is a little bit of physiology. So the parathyroid glands contain a cell called an oxyphil cell. Actually, the parathyroid gland contains three types of cells: fat cells, chief cells, and oxyphil cells. Now the cells which are of your use is the chief cells. The chief cells produce the parathyroid hormone. The fat cells is just fat cells. They get more in density in the parathyroid gland as we get older. But the oxyphil cells, we don't really know their function, but what we know is that they are rich in mitochondria. And the mitochondria are friendly with this isotope. So when we do this scan and the isotope is instilled into the patient, it goes in and it attaches itself to all the glands which have mitochondria in varying quantities. That is the salivary glands, the heart, and the thyroid, and the parathyroid. But because the parathyroid adenoma has a higher density of mitochondria because of the tumor, when we take the second image in 2 hours' time, the sesame B scan, the sesame B isotope washes out from the other glands. I'm going to show you scans in a minute, and the parathyroid adenoma stands out. So that's how it works. Sometimes, if it doesn't come out very clearly, we do what is known as a substraction scan. So what we do is, we then inject the patient with a radioisotope, which is based on iodine 123. And as you know, iodine goes straight to the thyroid. So the thyroid is fully lit up by the iodine 123. And then with computer software, they subtract it, and you get a filling defect, which is the adenoma. I'll show you these scans in a minute. Okay. So here you are. This is a biplanar, straightforward MEB scan. So the first picture, when the isotope is given, you can see the salivary glands are lit up, the thyroid is lit up, slightly dark on the left side, left lower pole. So when a second picture is taken after 2 hours, the salivary glands are still lit up a little bit, but the thyroid glands completely washed out. So, and you can see this very, very dense area. So this would be reported by the radiologist to me as a left lower pole parathyroid adenoma. Now, I consider it in my practice that this is basically a functional assessment, because the radiologist has shown me that this gland, as compared to the other two at the top and this gland is the hyperactive gland. So I have to match this functional image with an anatomical image of the position, and that anatomical image is the ultrasound. And I'll in a minute talk about the ultrasound. Here you see the sesame B, and here you see the ultrasound. So this is the thyroid gland, and this is the parathyroid gland. Now what the radiologist sometimes does is, he tries to help us by differentiating the parathyroid adenoma from a lymph gland, because some of these patients, they have thyroiditis. And when you have thyroiditis, there will be multiple nodes in that area, and the nodes on naked eye look similar to the parathyroids. But your radiologist can help you, because when they do an ultrasound, they can do a color Doppler. And when they do a color Doppler on an adenoma, they'll see much more vascularity on the surface of the adenoma. But if it's a lymph gland, they will see a hilum, and there'll be a single vessel going in. So that helps us, and obviously they put it in the report. What the other thing the radiologist does, and in our case it's Dr. Ward, is this is after years of mutual discussion, that he gives me a complete GPS localization. So he will describe this as behind the lower pole of the left lobe, adjacent to the trachea, related to the inferior thyroid artery, etc., etc. So when he does all that, and when you're marking your incision on the patient asleep, you put your finger on the cricoid cartilage, go down a little bit, go lateral a little bit, you know where it is, make the incision on top of it. The other thing which was picked up between the radiologist and myself was in the first year or two when we were doing this sort of surgery, I found that in a lot of cases, his description and my surgical finding would differ by 1 or 2 centimeters. So if he said it was just next to the inferior thyroid artery, when I would go in, I would find it was a little bit below or above, not exactly where he described it. So, and this is what my boss used to tell me, Professor Bradley Nottingham, that you must be very friendly with your radiologist, and whenever you have a puzzling situation, go down and talk to them and see the scans together, and you might find that. So I went down and I said, I'll watch you do a scan today. And in 10 seconds, I knew exactly why we were having that problem. And the problem was that the scans were being done with the patient flat on the couch. And I was operating on the patient with a sandbag under the shoulder. So anatomy was altered. So I suggested, why don't you do the scans in the same position as we operate? And then our accuracy got even much better. Small point, but makes a difference. So we've spoken about the subtraction. It's more useful in difficult cases, and the juniors who work with me know the more difficult cases are when you have an adenoma and the thyroid also has thyroid nodules. So when you look at it peroperatively, you will find many nodules. Now, which one is which can become a problem, but if the radiologist has identified with the two modalities, the radioisotope and the ultrasound, it becomes more helpful, but subtraction scan can be even more helpful. Now, this is a subtraction scan. So you can see, so this is your thyroid gland. You can see within the thyroid also there are a couple of lesions, but that's your adenoma very nicely. But if you look at this, he's now lit up the whole thyroid with radioisotope iodine, the iodine 123. And then you see the black bits, he's removed it, and you can see the adenoma quite clearly. So what is our local practice? Yeah, maybe scan with early and delaying imaging as a single, so the dual phase. Use of combined subtraction for the difficult cases. These techniques will detect mediastinal or ectopic lesions. And Dr. Ward also, and I will show you the scans in a minute, also does what is known as SPECT CT. He merges it all together, which gives us a three-dimensional position of the nodule. Because I'll give you an example. Earlier on in my career, I did a case in which the dual phase adenoma, the scan, this one, very clearly showed me that, yeah, it's on the inferior pole. So I went in, I looked around, and I couldn't find it. And if you've done enough, you know immediately that, oh, it's not there, something is not right. Now, the mistake some surgeons could do, and we are all surgeons here, is that when you know you're in trouble, you continue to dig a bigger hole. Do not do that. So I closed and I came out. And I went back and discussed the scan with the radiologist. And what I didn't realize was that I didn't have the scan to appreciate that, but that adenoma was on a deeper plane. It was actually sitting on the prevertebral fascia. And because I didn't appreciate on the depth, so now all our patients have a SPECT CT done as well, which I'll show you in a minute, tells us that. But what are the difficulties with radioisotope? Okay, patient movement, that's bad for MRIs as well. But then the sensitivity can be affected for one or two other things as well. Sometimes we get patients who have parathyroid hyperplasia. These are patients who have chronic renal disease. Don't rely on your MEB for them. Sometimes your MEB is negative. Be a bit alert that it is negative because this patient might have two adenomas. And then the most important bit is, remember what I said earlier on, oxyphil cells. Some adenomas will naturally have less oxyphil cells in the gland. And it is said that if it is less than 20% or the gland is less than 500 milligrams in weight, you may sometimes find that it doesn't light up as well as it should. But again, on the basis of experience, and again, I'm lucky in a way that I've got a very experienced guy. If the MEB is negative and the ultrasound, because ultrasound is always user dependent, if the ultrasound guy finds a gland which looks, and because remember, a normal gland is only 3 millimeters in size, but if he finds a gland which is 12 millimeters in size and doesn't look like a lymph node, doesn't look like a thyroid nodule, he will advise me that go for it in spite of the MEB being negative. So what I do is I go for it, but then I do intraoperative PTH. So I remove the gland and I do a PTH after 15 minutes. And if the PTH drops by more than 50%, I know that that gland was the gland, be it that it had less oxyphil cells, hence the MEB wasn't visible. And of course, for any of these things, if you don't have the right kit, you're not going to see it. I mean, you'd be surprised. I will not name names, but many big teaching hospitals don't have such a dedicated system to localize the simple parathyroids. And a lot of their surgeons just go in with the intention that, oh, we're going to do a 4-gland exploration today. So this was the biggest parathyroid we removed here. It was 6.2 centimeters in size. If you see, that's actually the thyroid lobe. And you look at the parathyroid, it's bigger than the parathyroid, bigger than the thyroid lobe on the side. And on the sesame B, even the first scan, it was so bright that, and this was one of the only cases in which I had to put a drain in because there was so much tissue mobilization involved, and the nerve was also identified because the recurrent laryngeal would have been at risk. And I kept the patient overnight because of the drain, and patient was successfully cured. This is just straightforward. The scans, I'm going to take you through a few. Again, this is the initial one, and now again, when you start doing many, your eye of faith will start appreciating. If you look at this very carefully, you can see there's only a subtle blush on this side as compared to the other. And then you'll start appreciating this. And then when you match that with your ultrasound, as here you can see, it's quite a big adenoma, you'll start appreciating. And for those of you who work with me, you know, it's good practice that you review the scans a few days before you operate, and then definitely review the scans again on the day before the patient goes on the table. And it makes so much difference because you're completely psyched, you know exactly where it is. It just speeds up things. And this is the color Doppler I was telling you about. This is the sort of image you get if it's an adenoma. If it's a lymph gland, you'll find a hilum with a single vessel. And again, you see, it's very subtle. And I mean, for me, this is positive. And the upper pole, for some reason, upper pole adenomas are not as common as lower pole adenomas. And the only tip I'm going to give you for upper pole adenomas is that if you're going to do an upper pole adenoma, just be very, very careful about the recurrent laryngeal nerve, where it literally sits with the gland. As a matter of fact, if you were awake when Saba was talking about it yesterday, he did say that if you can't find the gland, just follow the nerve. And if you go up with the nerve, where the nerve meets the inferior thyroid artery, you'll find the upper pole adenoma. I mean, false negative is, I've spoken about what the commonest reason is when you have 4-gland hyperplasia and chronic renal disease. So don't rely on MEB, rely more on your ultrasound. And you're going to do 4-gland anyway. Here, you see, this is what is, I mean, I can still say with my eye of faith that the lesion is here, but if you get a full washout and the ultrasound picks it up, I will just go for it. And it's very, very rare, especially with my radiologist who's very experienced, that we don't get the correct one. But of course, if you take this out and the PTH does not fall, then I'm afraid you have to open all 4 glands and take them out one after the other. Now, the smallest adenoma I have removed is 4 millimeters. And look at that. That's not very big. And look at the size of the thyroid next to it. Again, I'll repeat something which most of the trainees who work with me hear from me whenever we do parathyroids is your best friend on the day, because the radiologist is the best friend before the day. The best friend on the day when you're operating is your anesthetist. Because with the help of the anesthetist, you would be getting hypotensive anesthesia. And with your own skills, try and keep the field as dry as possible, layer by layer as you're going in. Because if blood touches the gland, the differentiation, because we read in our textbooks that the parathyroid gland looks a little bit brownish and orangish as compared to the thyroid. Believe me, it does. There is a slight difference in the color. But if blood comes on it, everything looks the same. And if you are going to have a real picnic, if you've got a thyroid which is multinodular, and you've got adenoma, and you've got blood, every nodule will look the same. So when I did this one, I distinctly remember doing it. It was just one of those lucky days where everything was going fine. It was bloodless. I got the thyroid gland and just rotated it, and I could see this nice little button, like the size of smaller than a shirt button, sitting there, different color from the thyroid. Removed it, and because it was so small, and you're not going to go in twice, I did a pre-op and post removal PTH, and the parathyroid hormone level dropped more than 50%, so I got it out. And in the sesame scan, as you can see, there's not much hint, but the radiologist had forewarned me of the side. So plan A, what do you do should be recommended for you to do normally. All patients should have sesame B and ultrasound. And like I said, the protocol in this hospital is they have it done before they see the surgeon. So the endocrine physicians, because we don't take any referrals directly from GPs for parathyroid patients. The parathyroid patients are referred to endocrine team who do the workup, do a diagnosis. Because remember, hypercalcemia, hyperparathyroidism is not the only cause for raised calcium. And then they do the ultrasound first, followed by the sesame B scan, etc., and the rest I've already spoken about. The ultrasound is, remember, user dependent. Now, in many hospitals, there will be multiple radiologists who will be reporting it. I mean, they're all good. Everybody has their, I can't do, it's like in our own ENT department, we have 6 consultants. 2 are otologists, 2 are analysts, and 2 are head and neck. I'm sure our otologists can also take out a parotid gland, but they might struggle. And I can also do a mastoid, but I will struggle. So similarly, all the radiologists, I'm sure they have the specialist interest. But it's always good if you have 1 or 2 people just doing this particular type of work. The 1 or 2 problems with the ultrasound localization in parathyroids are that if your parathyroid gland is behind the clavicle or if it's retroesophageal. So that sometimes can be a bit difficult to find. But if you've got an experienced guy doing it, like Dr. Ward, and if his sesame B scan gives him some hint, what he does is he hyperextends the neck if the patient doesn't have a neck problem and tries to angle the probe in a way that he can tell me, or if he can't, he just tells me that this patient might need a CT or something. So, yeah, there you are, just talking about it. Ultrasound missed lesion in sternal notch. As you can see over here, the 2 lobes of the thyroid, and this is slightly below the 2 lobes of the thyroid. So where is it? It's in the thymic tissue, and it's just behind the, I've done quite a few of these, and Dr. Watt has just flagged it up before the op. So what I do is, if the patient doesn't have a neck problem, just hyperextend the neck, and I literally, those who are with me will know, I operate from standing above the head of the patient. I'm looking down like that, just scoop it out, and it comes. Again, very subtle on the right lower pole. And you see Look at the anatomy of this one. So once you know it's there, this is the thyroid gland, and fortunately the thyroid gland is not nodular. If you keep it bloodless and if you just rotate the thyroid gland, you will see this tissue of a slightly different color. And because of compression, it's like long and thin. And you just gently, and again, these glands, the parathyroid glands, do not have a firm capsule. If you hold it with something very harsh, it's going to burst. And if you seed it, your patient is never going to get cured. So the trick is you try and hold connective tissue adjacent to the gland and use blunt dissection and just peel it off your thyroid. And look at this. It almost looks like a slug for those of you who do gardening. And again, your thyroid gland is there. Goes without saying what will happen if you have blood and you just can't see it. You'll miss it. Now, I've had 3 of these. The first one I missed, and I had to do the patient second go. So the sesame B scan gives you a hint where it is. You go in, you can't find it. Now, everything is good on hindsight, and when I was young and less experienced, I didn't appreciate that that can happen. So the second time when it happened, it was on a nodular thyroid patient. One thing I know, especially because of the confidence I have on my radiologist, that if he tells me it's there on the basis of his MEB scan, I'm pretty sure it is there. So the nodules, it was a nodular thyroid and it was on the right lower pole. I took it out, sent it for frozen section. They rang me to say it's thyroid tissue. So I took another one, again the same result. And then panic button started going. I said, right, where is it? So I took out several more samples and it was all coming as thyroid tissue. And then suddenly it occurred to me, go and see the pictures of the ultrasound. And I looked at the picture of the ultrasound and it appeared to me that it's probably stuck inside thyroid tissue. So I did a small localized lumpectomy of the thyroid and I sent that. I got a phone call saying that that was in the thyroid tissue and you got it. After that, I had a couple more, and in those, my radiologist had already forewarned me. So what you need to do is, when I consent my patients, I actually tell them that, and therefore I always consent them for parathyroid exploration. My consent form does not write parathyroidectomy. So I have a little bit of leeway there, and I warn them that if I need to take some of your thyroid tissue, it will happen. And that way you will get it out. Sometimes the difficult ones, and this is picked up by the radiologist, so you'll know it, but from your surgical technique point of view, I say it will be difficult because if it's stuck beneath the isthmus, if that is the case, you may have to mobilize the entire thyroid lobe and you must find the nerve. This side, it's because you have to dig in a bit more. You'll find it, but the good news is in most cases the radiologist will tell you about it before. This one was way down in the chest. Look at it. This is the thyroid, and look where the parathyroid was. Just to reassure you a little bit, in almost 370 parathyroids that I've done, I've only found 2 mediastinal parathyroids. But the good thing for me was they were picked up by the radiologist before I operated on these patients. And this is the difference, because if I didn't know that this existed, can you imagine me spending 4 hours in theater not finding, or finding a parathyroid, taking it out and finding I haven't cured the guy. So this patient was picked up, no problem, spoke to the thoracic team in Sheffield and the endocrine guys in Sheffield, and they helped out, and the patient had 1 operation and was cured. Plug, it's a term which was picked up again on the basis of going in, can't find it, etc. Basically, plug is posterior lateral upper glands. What happens is, some of these upper gland parathyroid adenomas, if they've been around for a very long time, And remember, we all swallow dozens of times every day. So with the repeated swallowing motion, etc., these glands, and because remember, these glands a lot of the time are just floating in connective tissue, loose connective tissue. They get pushed backwards and they sit on the prevertebral fascia. And if your radiologist will not pick this up, you will do what I did on one of my patients, went in, floated around the inferior pole, could not find it, and woke the patient up. Now, because we had that one incident, we picked them up, and there's another type of scan called a SPECT CT, and this is it. So what he does is he gives me these nice colorful pictures, and if you look at this, I look at the gland and see how far it is from the vertebra. If I see this gland is sitting there, I know when I go in, I'll go past the thyroid lobe and go towards the prevertebral fascia. And I'll say one thing for you guys, if you haven't done this, it doesn't sound as challenging as you think it does. Because if you've got your carotid sheath lateralized, if you've identified the nerve and stay away from it, you will go very nicely, and within minutes your finger will be touching vertebra. And if it's sitting there, it's very nice. I mean, you may have to use a slightly longer artery forceps to do the blunt dissection, but it comes out. If you don't appreciate it, believe me, you will miss it every time you go in. Because, I mean, this one is superficial enough that when you go in, you'll see it. But if it's sitting there and you don't realize it, you will not pick it up. Now, again, I will say it's not very common, but I would say you might have 1 or 2 in every 10 you're going to do. So that's still a lot. And you do not want negative exploration. This is again is a substraction scan. You can see the thyroid has been removed, and you can see the parathyroid over there. So in conclusion, I mean, we are a large DGH, and I've got a reasonable practice, but this is for anybody who does parathyroid surgery. If you are thinking of doing minimally invasive parathyroidectomy, your best friend is your radiologist. And the gold standard imaging is a good high-resolution ultrasound, followed by a MEB scan, and 4D CTs, MRIs, venous sampling, gamma probe, fluorescence, etc. You can keep for 1 or 2% of the patients who won't be picked up with the other scans. It does require a dedicated radiologist, and well, a surgeon who does that many will obviously be much better. And with ultrasound and cystomy, you will have, at least, I mean, 95, we have 97% pickup rate, so it's very, very good. And this is the guy I was telling you, the 6.2 centimeter one, and that's the gland being delivered. You can see, usually, I mean, I don't put drains in any of my patients except for this one. Usually, the parathyroid gland's feeding vessel is such a piddler, you can just buzz it with a bipolar. You don't even need to put a tie. This one, you can see very, very substantive blood supply. So I did put a little tie, and I put a drain in for 12 hours. And that's about it. Thank you very much.